Hello, everyone, and welcome to the Brian Grant Foundation's Wellness Webcast, sponsored by Kiowa Kieran and Neil. We have a wonderful presentation today. What better topic for Valentine's Day than sleep? Before I introduce our presenter, I would like to invite you to ask your questions in the chat box below, and we'll do our best to answer them. Now, I'd like to introduce today's presenter, all the way from snowy Connecticut, Dr. Michelle Dagostine, a movement disorder specialist with the Hartford HealthCare Medical Group and is part of the Chase Family Movement Disorder Center. He was in private practice overseeing a busy movement disorder clinic for 5 years, prior then leaving to go into research at the renowned Institute for Neurodegenerative Disorders. He then left the clinical research and is now at her current role at the Hartford HealthCare. Dr. Dagostine, thank you so much for joining us. I'm going to hand it over to you. Sleep is important. I know that everybody here has been plagued by a bad night's sleep, and please teach us some things and walk us through this.
Thank you, Amy, for having me. Happy Valentine's Day. Thank you, everyone, for joining. I'm going to go ahead and share my screen. Okay. So you just hide these controls here so you don't see a little bar. And go back to my topic slide. So today's topic, anyone who has Parkinson's or has, known somebody with Parkinson's knows how important sleep is and how difficult it can be to come by. So my topic today is the things that you should know and then what you can do to take control of your nights. I think a lot of times I hear in the office, I'm so tired. Sleep is such a big problem, but I don't think we do a great job sort of educating people about sleep in general and then giving you really sort of actionable items that you can do to make things better. So I want to give you some basic information on sleep. I want to let you know about the most common disorders that we're going to see with Parkinson's, and then talk to you about sleep hygiene. So sleep hygiene is one of my favorite topics to go into. I have no financial disclosures, no conflicts. Make sure this box is not covering anything. So about 60 to 98% of people with Parkinson's are going to have a sleep disturbance at some point during their life, right? I think 60 is an understatement. I think it's probably closer, honestly, to 100%. It's one of the most common non-motor symptoms that we see. What do I mean by that? So we have the motor, meaning shaking, stiffness, slowness, changes in your facial expression, changes in the quality of your voice. But we've also got all these non-motor symptoms that are really very contributory to your quality of life. And so sleep really is one of the most common disturbances we see, but it doesn't get enough attention. When you're not sleeping well, anyone on this call who knows someone with Parkinson's or has it, you see that if you have a bad night's sleep, shaking can be worse, balance is worse, your processing is sort of slowed down. It increases your risk of falls. It can make you more depressed. There's so many things that happen when we're not sleeping well that it's just such an important topic, and I'm glad I had the opportunity to talk to you about it. The sleep disorders increase, again, that motor burden, right? But again, it also increases the non-motor stuff, the depression, the anxiety, sweating, pain, all these other kind of things that we see, digestive issues. So when sleep is off, it's a massive stress on your body. And our bodies are still very primitive. Your body doesn't really know the difference between getting a bad night's sleep and getting chased by a tiger. Now, if you think about it, right, it's the adrenaline, it's the cortisol. When your body's under stress, we really don't have many chemicals that are going to get sent up to help us. A poor night's sleep, your body is just sort of in fight or flight that whole next day. And that's it, that really can make a lot of your other symptoms much, much worse. Okay, so let's talk about air quotes, normal sleep, if you can say that there is normal. There's 4 real stages, N1, N2, which are kind of the light part of it. Then your deep sleep. I'm going to go into these individually. And then you've got your REM, or your sort of dreaming sleep. The reason why I like to show this is because you're going to cycle through these roughly every 4 hours or so all night long. And if you understand the cycles, it's going to help you understand some of the sleep disturbances that you're having, right? So when I have someone who says, I'm going to bed at 9 o'clock every night. And, geez, 1 o'clock to 2 o'clock in the morning, I'm up every night. Okay, well, that's pretty normal because that's the end of one sleep cycle. And I'm going to go into that in some more detail. So stage one is really just, you've barely fallen asleep. Your body is not really fully relaxed. There's a little change in your brainwave activity. So if you put little electrodes on and you can look at the brain, a little bit of change, but not much. It's really easy to wake someone up out of this stage. Stage two is where you see that drop in people's body temperature. Drop in body temperature is a really important part of sleep. And that's why when people talk to you about setting up a good sleep environment, we want it nice and cool. You can see some issues in Parkinson's with the body temperature regulation and this being an issue. And there's some tricks for that. But here you're going to see the muscles really relax. Your breathing is going to slow down. Your heart rate slows down. Your brain waves are going to change. Now, this stage is going to last about 10 to 25 minutes. And as you go through these cycles, right, every 4 hours, this stage is going to get longer as the night goes on. You're going to spend about half of your time at night, hopefully in stage two. Now, if you're lucky, you will then move on to stage three. Some people with Parkinson's aren't going to make it into stage three because of discomfort or other things we're going to talk about later. But when you get to stage three, this is a deeper stage. This is where you're really strengthening your immune system. You are allowing for growth and recovery. But here, that muscle tone, it's really, really low. Your pulse is low. Your breathing rate is decreased. Here's where you're processing things from your day. This helps with your memory, your processing speed. Now, this stage happens most in the first half of the night. You're not really getting a ton of stage three later on. It changes a bit. And then stage four, which most people are familiar with, which is the rapid eye movement, your REM sleep. Now, this stage is interesting because even though this is a very deep stage of sleep, your brain is incredibly active. It's really almost as active as when you're wide awake. And if you do special imaging techniques and you look at how your brain is working and how active it is really, really so active during stage four. And that's why it's so important that we get you into stage four. This only happens once you've been asleep for about 90 minutes. So if you're getting up at the 60-minute mark to go to the bathroom, or you're getting up at the 60-minute mark because you're uncomfortable and you don't get to this stage, you're going to run into a lot of problems because you're not going to consolidate and really store those memories, learning, creativity, again, that immune system function. A lot of this stuff really happens in this stage four. And here, your body's supposed to paralyze everything that's not essential for survival, right? So that you can still breathe and your eyes are still moving, but everything else is supposed to be shut down, right? Now, this is supposed to take up about 25% of sleep in the typical adult population. This gets longer as you go through the cycle. So remember that stage three gets shorter. Your deep sleep occurs typically earlier in the night. Your REM sleep is getting longer as the night goes on. One of the conditions I'm going to talk about being REM behavior disorder is, I'm going to go into that in more detail, but what makes more sense is that a lot of people will have more problems with their REM sleep disorder as it's closer to morning, because now you're getting into these longer and longer periods of REM. So the most common that we tend to see is this rapid eye movement behavior disorder, REM behavior disorder. What's interesting is that this will typically predate a diagnosis of Parkinson's by at least, 10, 15, sometimes 20 years. We tend to see a lot of restless legs. We see periodic limb movements of sleep, excessive daytime sleepiness, sleep disordered breathing, and then nocturia, which means, you're waking up frequently to go to the bathroom. And each of these are going to be addressed separately. So let's start with the REM behavior disorder. Many of you may be familiar with this, but for those of you who aren't, it's a condition where when you get into that stage four of sleep, again, remember, everything's supposed to be shut down. And this is really for safety, right? We don't want you acting out your dreams or talking in your sleep because you could hurt yourself, right? In REM behavior disorder, there's a glitch. That hasn't happened. So the muscles are not paralyzed. So you're talking in your dreams. You're acting out your dreams. You are totally unaware that this is happening. So you really don't know that it's going on. It's not something that you can control. Typically, again, predates the Parkinson's by at least 10, if not 15 to 20 years. And it tends to kind of go in cycles where you'll have episodes for quite some time, and then you can have long periods without it. And then you can have it sort of again. Um, it's when the REM sleep is happening, you're having those very vivid dreams. I mentioned earlier, you have to get to at least 90 minutes in each one of those cycles before you can get into REM. And so again, early in the morning is when you're going to have the, more severe REM behavior disorder symptoms. And they really vary. You can have people who just sort of whimper a little bit or twitch. You can talk, shout, scream. You can have full conversations. What's interesting is because it's a different pathway, you can have people who have a difficult time moving during the daytime when they want to, but when they're sleeping and they're in REM sleep, they can move tremendously well. I've had patients rip headboards off of beds, do very purposeful actions. People can really hurt themselves with REM behavior disorder. Bed partners can also be pretty severely affected. Sometimes, again, it's a minor disruption, but sometimes it makes it so that you can't actually sleep in the same room as your bed partner. And for those of you who want to sleep in the same room as your partner, it's important to tell your physician that this is going on. What's really important here is that about 8 in 10 people with REM behavior disorder are eventually at some point going to hurt themselves, right? So that's why we ask about it. If it's whimpering a little bit, you're sort of not doing a whole lot, we don't tend to get too concerned, but your movement disorder doctor or your clinician is going to ask you about it at every single visit, because you can have these, talking, outbursts. You can have these motor activity outbursts several times during one night or not at all. And if we don't sort of pay attention to it, like I said, about 80% of people can really hurt themselves, and it can be pretty severe, striking your head on, a nightstand or something like that, or really hurting your bed partner. Just as a side note, obstructive sleep apnea can actually mimic this. So if you have untreated obstructive sleep apnea, you can have what's called pseudo or fake REM behavior disorder. And then when you treat the obstructive sleep apnea, it goes away. And so it's important to really sort of diagnose this properly. I know most of you are so sick of going to doctors and having stuff ordered, and I'm sorry, but all of us are going to bug you and beg you to please get a sleep study. We want to really see what's going on. We want to make sure we're not, calling something REM behavior disorder that's not, right? That we're not missing sleep apnea, which is a really relatively easy fix. I'm going to talk about that later. We want to make sure you're not having seizures. You can have different kinds of seizures in the middle of the night that can mimic REM behavior disorder. Frontal lobe seizures can be really kind of tricky. We want to, make sure that we're not missing another medical condition that's causing it, and that it's not a medication effect or a substance abuse problem, because we're going to tackle it from a different angle. I try very hard in my practice not to order tests that aren't going to change what I'm going to do, but I will tell you a sleep study is one that almost always is useful and changes management, or at least helps us with it. One of the first things we're going to do is, if you're someone who's talking in your sleep, you're acting out your dreams, we're going to have you take anything away from your bed that's going to potentially hurt you, right? So if you've got pretty glass bowls or, glass lamps or any sort of, objects on your nightstand that could be dangerous. Sometimes we'll have people move the nightstand away altogether, or put pillows or blankets in areas to kind of protect you, so that, if you do happen to have a violent movement, right, that's really unexpected, you're not going to strike your head or another part of your body on an object right next to your bed. Some people have to put the mattress on the floor, or, a mattress next to the bed in case you roll or fall out. It's tricky because just putting, padded bed rails or rails up doesn't always solve the problem in our world, because a lot of people are also going to have to get up and go to the bathroom. And the last thing I'm going to want you to do at 2 or 3 or 4 o'clock in the morning, or all of those times, is have to wake yourself up and try and figure out how to get up and around a bed rail when you don't have a ton of medication in your system and it's hard to move, because that's a great setup for a fall. So you've got to be really careful with that. Again, I mentioned before, some bed partners will sleep in a different room, and that's okay. But what you need to make sure of is that if you don't want to sleep in a different room, you need to tell your clinician, because that's a fair thing to ask for. And we can help you. And it might just be a different solution. I would never want someone to say to me, I didn't get to sleep next to so and so for all these years because I didn't know I had an option to, right? That would make me very upset. We want to avoid drinking alcohol in the evening because that can contribute to the REM behavior disorder. And then, when the conservative treatments don't work, we look at medications. We look at those second, not first, right? There's great data on melatonin. And a lot of people have experience with melatonin from 20, 30 years ago. You're traveling for work, or, oh, you were on a red eye and you take, 1 milligram or 3 milligrams or something like that, and it worked well. But you've tried it for your sleep disturbances with Parkinson's at those doses, then it hasn't worked. Those aren't the doses that we use for people with Parkinson's. When we look at REM behavior disorder, we're starting at least 5 milligrams. There are papers going up to 50, 50. I know I have a couple patients on this webinar. And I'm not a cowboy. I don't go up to 50, but you could. I don't tend to go past 20. But what you tend to want to look at is, when are you having the periods where it's most disruptive? Is it early in the night? It's usually not. It's usually later in the night. And melatonin is typically short acting. Melatonin is something your body has made since the minute it existed. You get this rise, used to be as the sun was setting, and it would tell your body it's time to go to sleep. It's not meant to knock you out. It's not a sedative. It's supposed to tell your body it's time to transition into and out of fight or flight into this sort of rest and digest. So for our purposes, you're going to want to take it about an hour or two before you want to go to bed every night for at least 2 weeks to see a benefit. And most of my people will need to be on a combination melatonin that has some short acting, but also has some long acting. It's called BI layer. You can get it over the counter, over at the pharmacy. But it tends to be more effective when you're having this REM behavior disorder early in the morning, because that one's going to last you into the early hours, right? Because that's when your REM periods are the longest. So if you have a quick 5-10 minute period earlier in the night, you're really less likely to really act out and get yourself into trouble. But if you've got a solid, 20, 25, 30 minute period at 4 or 5 o'clock in the morning, you tend to see more disturbances there. And when that doesn't work, clonazepam, Klonopin, is a long-acting sedative that is considered a gold standard for treating REM behavior disorder. It's long-acting, so there's very low potential for addiction, but it's something that you have to really talk to your doctor about, because it's not appropriate for everybody. As we get older, we all metabolize things. We break things down in a different way. So sometimes we'll use a middle-acting medication, but the purpose of it is to keep you safe, right? I use this when my patients, I had someone the other day who I've known for, 15 years, and he's on a blood thinner for atrial fibrillation, and he had a really bad episode where he hit his head on a nightstand. So we didn't want to mess around, and he's on a very low dose. We use the lowest dose you possibly can, but it can work very, very well. But again, you have to really have that conversation with your medical provider. The next thing we see incredibly commonly is restless leg syndrome, right? And sometimes I see people come in with what they think is restless leg syndrome, and it's not really what they have. So that's why I want to kind of go through, well, what is it, right? It's not just a sensation of feeling restless, because you can have that just with Parkinson's as your medications are wearing off or kicking in, right? That where you just can't get comfortable in your skin. It just doesn't feel right. That's one of those sort of non-motor symptoms. Restless leg, by definition, typically is in your legs. A little bit of a misnomer. It doesn't have to be. It can be in other parts of your body, but it's this intense, irresistible urge to move. You just have to move. And people describe it in a million different ways. Pulling, itching, tingling, burning, you name it. I think I've heard it over the course of my career. the sensations tend to come right when you're trying to relax. Now, typically it'll happen in the evening, but it can happen any time of day. Usually it starts in the evening. Usually it'll start either around sort of dinner time, after dinner, you're sitting down, you're trying to watch a program, and maybe after you've eaten. And the minute you go on trying to get relaxed, oh, you start getting the sensation and you just can't sit still. In those situations, people are getting up, they're walking around. And when you get up and walk around or you move, you have total relief of your symptoms. And that's important because when we're trying to sort of differentiate what is going on, that sensation, that drive to move, and then when you get up and move, when that sensation is gone, is very helpful in diagnosing restless leg. When we look at the causes of it, a lot of times, and this goes missed a lot, low levels of iron or anemia can be a big cause. You can have normal levels of iron, okay, but low levels of ferritin, which is a storage component of iron. And if that's low, you can have horrible restless leg that when we fix it, we fix those levels, it goes away. So it's important to consider some of these things. When you have thyroid problems, depression, things like fibromyalgia, peripheral neuropathy, kidney disease, diabetes, arthritis. So there's a lot of different things that can cause it or contribute to it. A lot of times with the neuropathy or the fibromyalgia, if you have pain or problems with sensation in your legs, your brain gets these signals that it sort of doesn't know how to interpret, and it can really cause this sort of intense need to move. So it's important, again, if you have any of these things going on, that your doctor's aware of it, that we're working it up. The depression comes up because a lot of times people will be using medications like selective serotonin reuptake inhibitors, SSRIs, things like citalopram or citalopram, venlafaxine, and those can actually make restless legs much, much worse. So when we're diagnosing it in the office, again, we're going to want to hear, where does it start? And a lot of times I'll say to people, I did just this week, show me with one finger, where does the sensation start? And usually people can pick out or pinpoint a spot either on their legs or their thighs, typically lower leg, but doesn't have to be. Oh, it starts here. And when it starts there, I know it's starting and I know it's going to be bad. And there's a huge psychological component to restless leg because it's one of the very few conditions where you can't escape it no matter how tired you are, right? So you're exhausted, you want to go to sleep, and the minute you stop moving, you're going to get this intense sensation. And anyone who's had it, knows it is so anxiety provoking that you're not going to be able to get a good night's sleep. That fear that sensation is going to come back is really quite bad. Again, it's worse at rest or inactivity. Has to be partially or really totally relieved by activity. And again, we want to make sure we're ruling out other medical problems. So how do we treat this? The regular exercise does help, but you want to do it in the first half of the day. Catch 22 here, getting enough sleep. So the more sleep deprived you are, the worse your restless legs are going to be. I know, and I say that to people and they go, well, yeah, that'd be great. I would love to sleep, but did you know I have restless legs? That's what I'm talking to you about. So that is really, really tricky. But the worse it gets, sort of, it feeds upon itself. You want to limit your caffeine, your nicotine, your alcohol. You really don't want to have any caffeine really much after 12 p.m. The alcohol, ideally, if you're someone who's really struggling with a sleep disorder, you want to just get rid of it. There's really no benefit to it. It's a central nervous system toxin. It just doesn't help. For some people, it'll help you fall asleep initially, but then you get the rebound, and that's a whole nother talk. One of the things that can be very helpful for people are using heating pads. You want to make sure you have an automatic timer to shut it off because you don't want to, fall asleep and have a burn, right? Cold compresses, massage, acupressure. Some people will put compression stockings on in the evening. And again, that's to treat that sensory sort of component. Some stretching before you go to bed or other sort of relaxation techniques. Soaking in a tub is great if mobility allows for it, right? The soaking in a tub means you've got to really submerge those legs in warm water, typically with like an Epsom salt or some magnesium salts in there, and they've got to be in there for at least 30 minutes. So you can't just sort of dangle the legs in for 10 minutes. It's not going to work. If you are someone who is able to get yourself into a tub or into an area where you can submerge your legs, again, you're looking for 20 to 30 solid minutes to really get that full absorption. Magnesium supplements are great. I like to use these a lot in my practice because almost everybody I take care of is constipated, and the magnesium supplements help with that too, right? So sort of two birds, one stone. Stress reduction is great. I wish I did have a magic wand for that. I know that that is much easier said than done. We do iron supplements. Now, these can be oral, by mouth, or through an IV. Again, I mentioned before, most people with Parkinson's are constipated. And so a lot of times with the iron supplements, what you're going to run into is that it's going to make the constipation unbearable. For some people, it makes loose stools, but not typically in our patient population. Slow release iron or slow iron is typically better tolerated, but for a lot of people who I take care of or who have very low ferritin, that number I mentioned before, that storage chemical, we in our world want someone to have a level of like 75 to 100. You can get tested and you could be at 35 and they'll say, well, you're kind of normal, but for our purposes, we aim much higher. And that can take 3 to 6 months to get to with oral pills. So a lot of times if someone has really low iron stores, I send them to our blood doctors, the hematologist, and they get an IV, and sometimes they go once or twice, and we sort of boost their levels. You would be amazed at how many people are able to come off of medications just by doing that alone. Then you've got gabapentin, which is the new sort of gold standard that was updated about 2 or 3 years ago. It comes in short acting. It comes in long acting. Carbidopa, levodopa helps, believe it or not. So I have a number of people who keep levodopa, whatever formulation they're taking. Typically, I like the just regular release, just 25/100. That 100's the levodopa. The levodopa is just the ingredients to make dopamine. And in your regular release, a lot of my people have it at their bedside. And if they're waking up in the middle of the night, they'll chew a tab, right? And that'll help them with any restless legs they're having in the middle of the night, stiffness and slowness, problems turning in bed, sometimes with urinary frequency. They wake up when they're not on an empty tank in the morning because they've gotten, a little bit in their system. We don't set alarms for it, but that is very helpful. The dopamine agonists, so things like ropinirole or Requip, pramipexole or Mirapex, Retigotine or Nupro, those have been approved and used in the past. They're no longer standard of care. They're not the first line. They can be kind of messy with their side effects. I don't love to use them, and I try to avoid them when possible. Opioids are used. We use Suboxone and methadone for people, so long acting. Again, these are, this wouldn't be my first go-to. I try and avoid these, particularly in Parkinson's people, because of the constipation and other sort of side effects. Our GI tracts are already moving slowly enough with Parkinson's. I don't love to use the opioids. But I do love botulinum toxin injections. So this is something that's been around for a little bit of time that, most people are not very familiar with. You can use botulinum toxin that we use for, the drooling or the dystonias. You can actually do sort of very shallow or superficial doses into the calves, the front of the leg. And again, I move them around sometimes. And what that does is it gets rid of that sort of initial stimulus trigger. I have some people who are only doing those, but most people will need to do that so that they can lower doses of other medication, so we don't have strong side effects from sometimes, taking those other pills. I want to make sure I have enough time here. Periodic limb movements of sleep or periodic limb movement disorder. This is, for any of you Seinfeld fans, the Jimmy legs, right? You're sound asleep. You don't know that you're doing it, but your bed partner sure does. And you're getting that sort of knee flexed, the hip flexed, the toe is extended. This happens during non-REM, right? And that's how we differentiate it from the REM behavior disorder. It's repetitive. It can be jerking, it can be violent kicking, and it tends to mostly involve the lower limbs. Every once in a while, you'll see it in the uppers, but typically it's the lower limbs. It can wake people up from sleep if it's really severe. Sometimes you think you've had a good night's sleep, but because of all the movement, it hasn't allowed your body to get into the deeper stages of sleep, right? And so you do wake up tired. For some people, it causes insomnia. It can happen every 20 to 40 seconds during sleep. So this can be quite violent. And again, a lot of times the bed partners are the ones who are saying, you are beating me up while you are sleeping. And it can be very, very violent at times. Very similar risk factors here. One I wanted to mention that is not listed in restless legs, but is relevant here are antihistamines. So a lot of people who are having a hard time sleeping will tell me, well, I take Tylenol PM. I've got a little arthritis. I take a Tylenol PM, or I take an Advil PM. If you look at the ingredients on the two of those, the part that actually makes you fall asleep is basically Benadryl. And Benadryl in people with Parkinson's it's like a 4-letter word in my world. We don't really like it. It can cause hallucinations, memory problems, urinary retention, changes in your memory and your cognition. It's just not a clean medication. And especially as we get older, you can see a lot of really bad side effects from it. So if you are someone who has, gotten yourself into a pattern where you're taking Tylenol PM all the time or something like it, I would bring that up to your doctor. For some of you, they may want you to continue it, but for a lot of you, it's going to be a better idea to get you off of that. You're going to see again, smoking, physical inactivity. People over 65 are more likely to have these periodic limb movements of sleep. And here in particular, if you have a family history, you are at a greater risk. And so here, the treatment here is about the same. The only difference you're going to see with the PLMS is that we don't do botulinum toxin injections. Now, I mean, the easiest thing to do if it's not waking you up and you have it is that you either could do like a larger bed if that's something that you and your partner have decided is acceptable. There are some people who, they're going into another room anyway, so it's not an issue. I don't throw a lot of medications at this. If I don't have to, they don't tend to work quite as well. And this is another one where you really, again, you want to, if you're the spouse or you're the care partner or a loved one, you want to bring this up in the appointment. Remember, when you're there, we're asking questions, but you're a team. And so as much as I want to know, how is your sleep doing? Because you're the person, you're the patient, as the other person in the room, I want to know, well, how's your sleep, right? Because as part of this team, your sleep gets impacted, and there's a big, big impact on everyone's quality of life if you're not sleeping too. So that's something you want to make sure that you are very forthright in sharing with your care team, because we care and it's important. Excessive daytime sleepiness. I mean, you hear all the time people will say, I'm tired, but when it comes to Parkinson's, it's really a different beast. So when we talk about excessive, okay, what does that mean, right? This is with Parkinson's, those waves that hit you where you should be wide awake, and all of a sudden you just get this, you can't stand it, this drowsiness that comes over you, and you just have to sit down or go to sleep. You can't function. You're exhausted. You're absolutely wiped. It can happen at any time of day, but usually people have a time of day when it happens most commonly. And it's different for different people. I have some people where that wave comes on them. They get up in the morning, they've had their breakfast, they take their meds, and they're in a chair and they're sound asleep and snoring, and their care partners are going, you just woke up, right? And then I've got other people where, it could be 2:00 in the afternoon. It really just sort of depends on who you are and what you're taking. The numbers are 21 to 75%. I'm going to say it's higher than 75%. I think it's underreported, because I don't know a single Parkinson's person who isn't exhausted at some point. I mean, I don't know that in 20 plus years I have ever heard someone come in and say, I just have so much energy, I can't take it, right? Very rare. And there's a lot of things that go into it with the Parkinson's, right? You can be tired when your medication wears off. You can be tired because you haven't gone through your 4 stages of sleep, because you can't turn in bed because you're stiff or uncomfortable. You're getting up to urinate every couple of hours. When you're sleeping, when you've got Parkinson's, sometimes it's like, you're charging that cell phone, but you didn't plug it all the way. And so, yeah, are you asleep for 6 hours or 7 hours? Yeah, you're asleep, but you're not fully charging. So you can be exhausted. And then, we're to blame too. If you look at the side effects of every single medication I have to give you to help with movements, right? And with symptoms, every single one of them is going to say fatigue. Every single one of them. So a lot of it's just the perfect storm sort of everything coming together, right? So when you come in and you say, just bone tired, I'm exhausted, there's so much I want to do. I want to get out, I want to be active, I want to do these things. I'm exhausted and I can't plan my day. We're going to ask a whole bunch of questions. Are you falling asleep at the wheel? Are you falling asleep during conversations to kind of gauge, what's going on? We are going to beg you for a sleep study. I mentioned it earlier, and I'm sorry, but we're going to beg you because we want to see what's going on. You're going to want to minimize medications that are sedating if you can. Sometimes it's as simple as changing the formulation, right? So, the carbidopa, levodopa. Okay. It comes in a lot of different forms. It's been out since 1967. It's still our gold standard. If you take the regular release, it's going to, especially on an empty stomach, it's going to peak and crash. As it's peaking, you're going to get the majority of your side effects. So sometimes what we'll do is give a longer acting version or something that has a little long and a little short, so you never get up to that peak that knocks you out, right? So sometimes we have to modify what we're giving you or change the time that we're giving it to you so that we're not making you sound asleep in the middle of the day when you want to be out going to different events and, going out to meals with friends or going to an exercise class. So whenever people say they're tired, another thing we do that I know is annoying is we'll say to you, well, can you track it? Can you just for a couple days go home and kind of keep a little list? Okay, like I take my dose at 8. When am I tired? Am I tired at 9 o'clock? I mean, maybe that's peak dose, fatigue that we're setting in. When is it happening? I always run a bunch of labs. A lot of people are a little behind in getting blood work done, either because, weather constraints, getting a ride places, it's hard to get out and get to places. Sometimes blood draws are just really hard on people because they're dehydrated or what have you. So I really want to make sure we're not missing something that's very fixable. B vitamins are always a hot topic with this. Don't go supplementing yourself if you don't know that you have low levels. As a matter of fact, more commonly now is I'm finding people with levels of B vitamins that are actually quite high. It takes a lot to cause a problem with a B vitamin, but I have seen nerve damage when those levels are too high. So again, that's one of those things where you don't want to just kind of go, supplementing if you don't have a deficiency. So you want to check that blood work. And then we're going to check for depression and treat it if we can. When you have a disease where you don't have enough dopamine, which is a feel-good chemical, it's very difficult to feel great. But when dopamine levels are low, your serotonin levels are low. So depression in Parkinson's is very different than depression in people who are not living with Parkinson's, right? And I have a lot of people say, well, I don't feel depressed, but they don't feel right in their own skin either, right? Or I've always been a little anxious, but now it's taken on a whole new character, right? So these are things, again, you want to talk to your clinician about because it's important. And then for the treatment here, again, we're going to review the medications, optimize your sleep hygiene. I'm going to go into a little bit more stuff later with sleep hygiene, and I'm running out of time because I want to make sure I leave you with time to ask questions. But the stimulant medications we do use sometimes if it's safe. So there are medications that sometimes doctors will give you if your heart is okay and everything else is all right, where we will give you a prescription for a little stimulant for early in the day. But a lot of people haven't even tried something as simple as caffeine. And if you're going to do that, again, you want to do it earlier in the day, but a little bit of caffeine sometimes goes a long way before you're having a prescription stimulant. The sleep disordered breathing, I'm going to skip through this a little bit. I think everyone knows about obstructive sleep apnea, but what I did want to just mention here briefly for time's sake, is that a lot of my female patients, and my men will have a difficult time maintaining their weight. They're losing a lot of weight, and we're trying to keep weight on people. When you sit there and I talk about sleep apnea, everyone I think has an image in their brain of like that bigger neck, someone who's snoring really loudly, but especially women, you don't have to fit that criteria. Women typically after menopause have very high rates of sleep apnea that goes undiagnosed because we don't have the same symptoms that men do. Women present with anxiety and fatigue. A lot of things present as anxiety in women, and then people want to throw medications at you for anxiety. But men are diagnosed 8 times more than women because we don't fit sort of the flow chart that people are used to. So especially as a woman who might not have a care partner or a bed partner to say, hey, you're snoring or you stop breathing, it's really important when we say to you, hey, you're exhausted, let's just check. Humor us, do the home study, see if we can figure out whether or not you've got sleep apnea, because that really, really helps with the fatigue, anxiety, and the depression. All right, I'm going to just skip through that. Nocturia, I'm going to spend a little bit of time on. This is having to urinate frequently. In Parkinson's, we see this very frequently. Now, anyone over 45 or 40, you've got a little bit of needing to get up and go to the bathroom in the middle of the night. But in Parkinson's, for whatever reason, we see very, very high volumes of urine output overnight. You can cut your fluids off at 5 o'clock at night, go to bed at 10, and have gone to the bathroom right before you went to bed and put out gallon of urine overnight. I don't know what it is. I wish I knew, why it was happening. We think it's probably related to some autonomic changes. But I will tell you, my men in particular, I mean, it's all night long, and the volume is tremendous. And so when that happens, and you're up every hour, you're not getting into those deeper stages of sleep, and you're going to be extremely tired. So we in our group, because it's a center, we have a urologist who works with us. I would encourage any of you who are having problems with this, don't pass go, don't suffer with it. I would go to the urologist. There's a lot of things that they can do. There's all kinds of medications. Sometimes they can even do Botox injections to your bladder, which has been a real game changer for a lot of my patients. I don't find that limiting the evening fluids tends to really fix the problem in people, although we tell you to do it all the time. I mean, you don't want to, drink 20 ounces of water with your nighttime pills. And then in some cases with people, we will do a catheter, sometimes a condom catheter in men or a regular catheter, because it's just so disruptive. But there's a lot of things that can be done. There's even bladder like pacemakers that they can do. So I would really strongly encourage you that if you are waking up really more than 2 to 3 times a night, even that I think is excessive, that is making your motor and non-motor symptoms so much worse than it needs to be. I would really try and go. And if you go to a urologist who's not a good fit, fire them immediately and go find somebody else, right? I don't want you to go to someone and have them kind of not work with you or not be the best fit for you, and you to then suffer for the next 10, 20, 30 years because it wasn't the right fit. Because that happens when you go to different providers. It's not always going to be a great, interaction. And if it's not, don't let them rob your sleep from you, right? I'm getting in my soapbox. I want to make sure I've got time. Okay, so these last 2 slides are sleep hygiene. And I drive my people crazy with this. Falling asleep, staying asleep, there's such a psychological component, right? You've heard of Pavlov's dogs and sort of training yourself and creating these habits. Sleep hygiene, the habits that you have right now could be pretty poor. We saw a lot of problems with this, especially during the pandemic, where people were staying up later, they were sleeping in later, they had phase reversals from day to night. You're going to bed at 8 o'clock because you're tired, your motor function's not the best, you're taking your pills, but you're not really ready to go to sleep. And so now you're laying in bed 2 hours, 3 hours, 4 hours, and you're on screens, you're watching TV, and now you've trained your body to think, well, this is where I go to solve the problems of the world. This is where I go to, watch the news. This is where I go to watch murder shows, and it's not where you go to relax. And so you've trained your body that this is not where you sleep. And so what you've got to do with sleep hygiene is really undo what you've done, one thing at a time. And it can take a long time, but it's going to work better for you than any pill I'm going to throw at you. Throwing sedatives at people to help them sleep is a very slippery slope. Now, we do it when we need to, but I worry a lot about people falling in the middle of the night because, again, we're getting up to go to the bathroom. We can't turn in bed. I don't need you tired and confused and sort of groggy on meds. If we're able to fix it with some of these behavioral changes. So, in a perfect world, and nobody's perfect, you want to minimize or really eliminate your screen time 2 hours before you go to sleep. Now, is that realistic for everybody? Probably not, but be smart about what you're watching, right? Are you going to want to watch, great example, so Super Bowl's on the other night, right? And it finished after 11 o'clock. I'm usually in bed at 9, so I'm on the East Coast. And, I was all wound up. Like, that is not a great way to calm yourself down to go to sleep. You're going to want to watch something that's relatively pleasant and boring, not the news. You don't want to have alcohol or caffeine. Those are really, really going to disrupt your sleep. Even like I said, if that alcohol knocks you out, you're going to get the rebound. You're not going to get that deep sleep. You're not going to get the REM sleep. You will have been plugged in, but not recharging. You want to do your exercise in the morning. You don't want to do heavy meals close to bedtime. Now, most of you are not, although I do have my snackers, right? That ice cream, the chocolate, those will give you those dopamine hits. And I find, a lot of my people are really, they love those sweets, but your body's going to be processing that. And when your body's working hard to process food overnight, your heart rate will lower later in the night. You're not going to get that deep sleep. So you really want to try and avoid that, push that up. You want several hours before you go to bed where you're done digesting and your body can just go to sleep and do what it needs to do. Your room, as I mentioned before, you're going to want it dark and you want it cool. The caveat here is that if you're someone who needs to get up to go to the bathroom, I don't want your room so dark that you're going to get hurt. So whether you have little lights that are motion activated or you have little lights like in the bathroom, you want to obviously make sure you don't have throw rugs or anything you're going to trip on. But in a perfect world, dark and cool. There are cooling devices that you can buy to put on your mattress. So if you are someone who has a difficult time regulating your body temperature because of the Parkinson's, you can buy these devices. Not affiliated with any of them, but you can make them warmer and you can make them cooler. And then you can make it so they sort of cool down at a certain time at night and sort of warm up in the morning to kind of wake you up. And so that's a really nice way that if your body's not doing that naturally, you can outsource it. You can do that. It works really nicely for people. When you're in your room and you're in your bed, the only thing that happens is sleeping and snuggling. If you are a mobile person and that's an option for you, right? Sleeping and snuggling, that's it. And if you're laying in bed and you're able to, if you are physically able to, and it's not going to cause you to have a fall or a problem, if you're in that bed for more than 20, 30 minutes and you cannot sleep, you need to get up, get out of the bed, and go do something very boring. I don't care if it's watching paint dry, but you want to get up and move because you need to train your body that this room, this space is where you go to sleep. Not worry, not be stressed, not stretch your legs, not, think about some visit you've got going on the next day. You need to get out of that bed and really sleep, snuggle, and that's it. Exposure to early morning light is important, right? We have all of this artificial lighting, but it doesn't have that full spectrum. Again, this is, if you can get out and you can get some early morning light for even a couple of minutes, that's great. And if you can't, you can outsource it. You can get the light boxes that they are readily available online. And early morning, put them close to your face. They have all kinds of instructions of how long you need to do it. But you want that light to hit the back of your brain and say, it's time to milk the cows. It's time to wake up because you want to get back on that schedule that we're sort of meant to be on. You don't want those day and night reversals because that's not going to help you go to exercise, go out with your family, go out to dinner, be social, which are just so important for everything, for quality of life, right? And you want to maintain your routine even on the weekend, as much as it's annoying, and I do this myself, 6 o'clock in the morning, doesn't matter what day it is, I'm up. Now you can take a nap. And it's okay if you take a nap as long as you don't have problems falling asleep later. But if you're up at 6 o'clock or whatever time you decide, on the weekend and you're tired later, just make sure you're not sleeping really for longer than about 40 minutes. You don't want to get into, you don't want a full sleep cycle. You don't want to get into the deeper stages of sleep because then you're going to wake up actually more tired than when you fell asleep. So maintain that routine. And then if you are someone who's dozing off in your chair, you gotta, ask someone around you to help kind of wake you up and not let you snooze. Because if you're napping all day long, you're never going to sleep at night. And again, we saw a lot of that during the pandemic, where people were really kind of snoozing all day. And then, man, it's time to go to bed and you're wide awake. Well, you've cumulatively gotten your 8 hours of sleep, but you've gotten it in these snippets that never got you into that good, deep, restorative sleep. So a little bit over, but I have lots of time for questions now.
Dr. Dagostine, that was so wonderful. Thank you so much. I have a question. When you talk about screen time, does that also include like the reading tablets that are not like the e-readers? Is that
Yeah, so
considered a screen?
it depends on which e-reader you use. If you use
Mhm,
like the classic readers that are like the Paperwhites that don't have the
mhm.
blue light, they're not as bad. I mean, it's still a little bit of light, but I those are not terrible. I don't have a big problem with those. A lot of it is more like the iPads where you're having like that full spectrum.
Mhm.
And I know they sell the blue light blockers. The data on those is not fantastic. There's even ones you can get that are they use them for people who use lasers in the field. I even bought a pair to try them out. It's really creepy wearing those with an iPad. Everything is like gray and black, and those also do not work.
Oh, um, let's see. Somebody had a question about like homeopathic medications, Highlands, leg cramps. Um, any thoughts on that, or just kind of? Mhm,
Yeah, no, usually when you look at the ingredients on those, you're seeing things like magnesium. A lot of times they have magnesium in them. I think as long as your doctor knows what you're taking, it's okay to try it. We work with a naturopathic doctor in our center. Dr. Secor is great with us because, you get good quality things, right? So that you know that you're getting what you say you're going to get. And you see what's in it. Now you want to be careful with certain supplements. So like St. John's wort was really popular, I don't know, 20, 30 years ago. Now you can't take St. John's wort with rasagiline, for example. You can't
mhm.
take that with some of our other medications. So as long as you bring it in and the person prescribing your meds knows what you're taking, and it's a reputable brand, I think it's okay. And I have some
Okay.
people who take stuff and it works really well.
Do you have recommended dosages for magnesium supplements?
Really depends on the person. I mean, the standard dose is
Mhm,
usually about 400 milligrams. Now, sometimes with the 400, some people will get diarrhea from that. Most people that I work with don't. Um, you can start with 400, but I would take it for at least a week and see how you do because there can be a cumulative effect. You can go to 800. Usually by 800, or I usually don't go higher than 800, and it usually
mhm.
works pretty well. But you can also, the medical team that you're working with, if you have a compounding pharmacy near you, they can even compound into creams, magnesium and a couple of other different, topical lidocaine and things like that. You have to do it under a prescriber's guidance, but we've come up with some pretty neat solves that you have to talk to your doctor about, but you can put on, which work pretty well.
I've got a couple questions about these like human dog beds. I guess they're
Hmm.
these, giant cushion beds with a rim on it. Any
Hmm.
thoughts on having those on the floor and using those?
Yeah, I mean, there's no issue with that. The only thing that I can see as being a problem is that they're very soft, right? And
Hmm.
so if you're someone who is having difficulty rolling in bed, firm mattresses tend to work a little bit better, right? The other issue is, can you get up off the floor? Can you get down on the floor safely? Can you get up off the floor safely, right? If you can get up and down and it's not an issue for you and it's not hurting your back because there's no support and you're able to roll over, I don't see anything wrong with it. I've got some people sleep in all different kinds of in different, chairs and recliners and things like
Hmm.
that. I mean, I think it's a personal preference. Safety is first and foremost. So can you get up at your most
Okay.
tired on your worst day and safely get yourself to the bathroom? And if you can, or get up for a fire, like that's okay with me.
How long does Botox work for restless legs? Is it different for each person?
So once you have the right dose, you have to find the right dose for each person. It takes 7 to 10 days to kick in. the peak effect, so the best it's going to get is at about 6 weeks, and then it completely wears off by 3 months typically.
Hmm.
Just because the way that Botox works, it stops the nerve ending from sending out little packets of chemicals, and it regenerates every 90 days. In a perfect world, we get you on a dose where you don't feel it kick in and you don't feel it wear off. And you kind of go, I'm not sure if it's working. And that's kind of what you want. You don't want to feel those peaks and crashes.
Hmm. Um, what would you recommend for somebody waking up at 4:30 in the morning? So, we discussed why it's happening. So, should you get up and go out and about and come back to bed at 4:30, take another dose? What would your recommendation be for somebody who's getting up at, almost
Yeah.
morning time?
So that's tricky. Couple things. First is, what time are you going to bed? The next is, when do you want to be up for the day? So if you're someone who went to bed at 1 o'clock in the morning, that's a lot different
Mhm.
than someone who wants to be up at 6. Um, if you're someone who's waking up at 4:30 and you're restless and you're having non-motor symptoms where you're having some shortness of breath or some sweating or some anxiety or restless legs, yeah, I'll have you chew a tablet, or a half a tablet of just the regular 25/100. If you take it with something with bubbles or vitamin C, it's going to kick in faster. But I would still do that because that's not going to typically make you drowsy at 6 o'clock in the morning. And there's a lot of people who will take a dose first thing and go back to sleep for an hour or two and then kind of wake up with their pump primed, so to speak.
Mhm.
The other thing to kind of look at is, are you having some autonomic issues? Is your body getting too warm at 4:30? Right? You can sometimes tell that with the different devices. If you've got like a smart watch where they're measuring your temperature. Like I wear an Aura ring, so it'll tell me my temperature and things like that. Or you can just get up and say, geez, I feel like I'm 100 degrees and I'm sweating. So it would kind of depend on um what meds you were taking, what time your last dose of medication was, what time you had woken up before 4:30, what time you want to wake up in the morning, like that kind of a thing.
Mhm.
But I wouldn't be opposed to having someone take a dose at 4:30.
Okay. I have somebody saying they wake up a lot. They're not sure why. They go to the bathroom, but it's kind of they're up, so they do it. Would you recommend a sleep study for that?
Yeah, so I would definitely do a sleep study to kind of take a look at, sort of what could be going on as a trigger to wake them up. But the other thing I would look at is medication timing, because I find
Mhm.
that happens a lot of times in people who are dosing 3 times a day, and maybe their last dose is at 5, 6 o'clock, and you're going to bed at 9 or 10 o'clock at night, or even if your last dose is at 8 and you've worn off, there's no gas in your tank. Now, you don't need necessarily a full, complement of levodopa all night long. Some people, who've had it longer do. But a lot of times what I find is that, you're getting the motor of, I can't turn, I can't move. You're on a pressure point where in 20 years ago, your body would not have had to wake you up. It just, you would have had the pressure point, and then as a natural sort of self-defense, you would have rolled off of it. But now you're not, right? Because now it's harder to move in bed. So sometimes it has to do with medication overnight and things like that. Sometimes it's the urinating, and sort of like a bladder spasm, but a lot of times it's medication, a lot of times. But the sleep study I think is really helpful.
Okay. I have a question about, we know that there is a correlation with women and their period, their cycles, and the effectiveness of the medication, etc. Um, and a lot of women complain that during their period week, they're having trouble sleeping. So for this like intermittent
Mhm.
sleep disturbances, what would you recommend?
So a lot of times, so the week leading up to and the week of for my younger patients is a
Hmm.
battle. It's a big battle because you've got, all the fluctuations in the hormones, and those play a big role in sleep. If if you're someone who is able to safely take hormone replacement therapy, right? So if you don't have a risk, a lot of times what we'll do is just a continuous cycle, of replacement in the form of like a low dose pill, right? So that's something that can be very helpful because then you're sort of avoiding the peaks and crashes. A lot of times too, what you'll notice are change in temperatures in those people. And then sometimes, you do need a sleep aid, you know, I would say at least 72 hours before. So let's say, day 28, your regular. So day 25, I'm going to have you start taking something so that you're building into it, right? And then you take it the whole week and then you stop, right? So that you're sort of preparing for it. There's a lot of different tricks for that. And part of it is sort of giving people something that they can take in an emergency too, because there's also that psychological component of, oh my God, this is coming. I'm bottoming out. I'm not feeling great in my own skin. My need for dopamine is higher and I can't meet that demand. My need for serotonin's higher right now. I can't meet that demand. So a lot of it is sort of working together to kind of parcel out, where the need is. Is it serotonin? Is it the dopamine? Is it a temperature thing? So yeah.
Okay. Well, we have come upon the hour. This went by so fast, and I know there are so many more questions out there. I'm sorry we weren't able to get to all of them. Dr. Dagostine, thank you so much. This was just an enlightening, informative, and helpful. I know we have a lot of comments saying that people have learned a lot. I want to thank everybody for joining us today. I hope you were able to walk away with something to help us all get a better night's sleep tonight. I look forward to seeing you all next month for our wellness webcast. Have a wonderful day, and thank you.